remain sacred to the Pawtucket and Massachusetts people. The United States government entered treaties with many tribes, which promise to deliver health care to the descendants of those who signed these treaties. It is our responsibility to provide access to high-quality, evidence-based care that is inclusive of and provided in partnership with Indigenous communities. In line with today's theme, Systems and Communities of Care, we invite attendees to examine how your practice can better serve your local Native community. And when we distribute the slides, you can see how to learn more about Native land and your local context where you practice. So today is the 5th annual conference that we've been sponsoring, and it is an act of love. Many of you are here because you are working directly with people who are experiencing early psychosis. Many of you are here because you are clinical researchers, and some of us are here because we work in administrative or bureaucratic roles, trying to provide the resources and support to all of you. And that's part of what today is really celebrating the work that all of you do. I think many of you were involved. Every 2 years, we do fidelity reviews of each of the programs in Massachusetts. And many of you were involved. It's a very laborious process. And so I just want to let you know that a lot of what you're going to be hearing about and the posters that you are reviewing are based on the work that you do every day, on the clinical assessments that you do, and on your commitment to working with us to do high quality clinical care and also to collect regular assessment data so that we can really evaluate and sort of hold ourselves accountable to whether or not we're helping the people that we're trying to help. And you'll hear, I think there's a poster from Nicole DeTore about, this is sort of a, oh my gosh, spoiler alert, that one of the things that she was able to demonstrate is that here in Massachusetts, the programs that have higher fidelity have people that have better clinical outcomes. Now, you would think that would be obvious, but it's not. And it's a really important sort of testament to how hard everybody is working, and that when you're really going to those consultation calls and learning the skills for the different treatments that we're offering, that when you're maintain fidelity, people do better. And so I think that's something for all of us in Massachusetts to be really proud of. And I think the other there's many noteworthy findings from Nicole's research, but the other one was that our community clinics do as well as our academic medical centers. So I think many of you know we have academic medical centers that have been doing this work for 20 years. And then we have community clinics that have come online in the last 5 years or so with all of the troubles that we all experience in terms of staff turnover. That's the biggest challenge, right? Staff turnover, filling positions, and that our community clinics are doing as well as the academic medical centers who've been doing this for 20 years. So I just want to say congratulations to all of you and thank you. And then just to acknowledge that all of the work we do together is a partnership with all of you, but also MapNet under Dr. Keshavan and Kelsey Johnson's leadership with the Beth Israel Deaconess. They make today happen, but they make what we do every day happen. And the LEAP Center at McLean under Dost Onger's leadership is essential to the community of learning that we all are a part of now. And then last but really not least at all, SAMHSA is an incredibly important partner with us. They oversee the funding that each of the states get to really support early psychosis work. And so we could not be doing any of the things that we're doing here were it not for SAMHSA and the funding that we get through the 10% set aside, which is part of the mental health block grant. So on that note, I'm actually going to invite Scott Gagnon and Laura Grubb from SAMHSA to come up and say a few words.
Good morning, everyone. First of all, everyone knows SAMHSA. Is everyone familiar with SAMHSA? Okay, great. Laura and I are from the regional office for SAMHSA for Region 1. And my name is Scott Gagnon. I'm the regional director for Region 1. So it covers the 6 New England states as well as the 10 federally recognized tribes. And we're very happy to be here with you all today. How many people have ever interacted with your regional office? All right, so a couple hands. So our main role in the regional office is really to be kind of a representation for SAMHSA here in the region. And it's really bi-directional. It's the grant funding that you heard about, it's the resources that we can bring to the region, but also, and the really important part of why we're here today is to be able to take information back to SAMHSA, to headquarters, to hear what's going on the ground, the challenges, the successes, and feed that back to headquarters to inform all things grant making, resource development, et cetera. My personal background is actually more in substance use prevention. And so that's why I'm going to let my colleague, Dr. Laura Grubb, one of our 2 regional behavioral health advisors, do more of our remarks. We do have one other member of our team, Rachel Braze, who's not with us today, but we're a great team of 3 here to be a resource for you all and all of your work. So definitely, be in touch with us whenever we can help. With that, I'm going to hand it over to Dr. Grubb.
Try not swallowed by a podium. Yes, here we go. Okay, that's me. Hi, nice to meet you. I just joined SAMHSA about 6 months ago. I'm actually Boston based. Our regional office is in Boston. Scott's actually in the Maine area. Rachel's in Boston as well. So we are pretty local for this group, depending where you are. So one thing is my background is I'm actually a pediatrician and adolescent medicine specialist. And I joined SAMHSA mainly to kind of pivot to a more kind of policy and advocacy role. I think in terms of this particular topic, I think it's so important because so much of what happens occurs first in primary care. And it comes in the door and you're not prepared, right? I wasn't as a pediatrician. We don't train pediatricians for psychosis. But yet I started noticing that my teenagers and young adults were starting to exhibit some pretty concerning signs and I needed a lot of help. What I'm going to offer today to you is actually resources that I discovered SAMHSA has that I wish I'd known about while I was in clinic working with first-time patients, with psychosis. So this is quick. The QR codes are here. I've asked everyone to please provide you with these resources. I just want you to know what's out there because I think SAMHSA, what we do is we make great products and then we don't disseminate them. So this is really quick. That's actually, this is it. So first of all, 988, is everyone familiar with 988? Okay, 988 is actually appropriate here as well, because what you get is when someone's in crisis, you get a crisis response. You don't get a law enforcement response. It is a text, chat, and call line. It's available in English and Spanish, and we actually have separate pathways for veterans or LGBTQ individuals. So that's why I bring this up here. And then SAMHSA actually has a early serious mental health treatment locator. Did anybody know that? Yeah, me neither, right? So here it is. You go online and you can actually put in your location and it will help you find resources for trying to get this type of care. Is anyone new that we have a new maternal mental health hotline? So this, yeah, isn't that amazing? Like it's so helpful. So this is for people that are pregnant and also postpartum that may need care. I think this is really important. And it's available in text and chat, also English and Spanish. So this is something as a pediatrician, when I saw parents come in that were overwhelmed with a newborn, I wish I'd known about, which it didn't exist. So here we are. And then the National Helpline can provide a lot more triage. And what's actually nice is that particularly if you're dealing with things like substance use disorders, also this can be particularly helpful. And then we actually have an early serious mental health training center, which provides webinars and other trainings online. Everything's free. Some of the things are live, and if you miss a live event, you can go and watch the recording and see the slides. So this is available here. And then we have a number of publications. So there's one on first episode psychosis and co-occurring substance use disorders, which I actually have helped in the past author these publications. They're really evidence-based driven, but they're very holistic as well. So I think they're very helpful. And then I see someone trying to capture, so I'll wait a second. Got it? Nailed it? Yeah, okay. And then there's actually one that's called Coordinating Special Care for First Episode Psychosis. What I think is nice about this is very practical because it also talks about funding, which, as we know, we can say there's all these great resources, and then funding always becomes the linchpin for everything, right? And then there's also an evidence-based publication on cognitive behavioral therapy for psychosis. And just a really nice fact sheet. What I like about this fact sheet is they have two versions. There's one for caregivers and there's one for patients. So, you know, just kind of explaining the nuts and bolts of like, what are you experiencing, or what are the symptoms? You know, what are the next steps? How do we kind of triage from there? It's broken into a language that's really relatable for everybody. So, and then I think Margaret and I were talking about MECPAP. You know, MECPAP is in Massachusetts. That's the Child Psychiatry Access Program. It's invaluable. But also, should you not be in Massachusetts or you're working with a colleague in another state, there's actually a national network to do this sort of work. So it's in all 50 states at this point. It's very helpful. And then we have our practitioner training. Did anyone know that there's like we have all these technical training centers. It's on the SAMHSA website. I didn't even know until I joined SAMHSA, and now when I have free time in my schedule, I just show up and learn. So it's great. And that's me. That's my contact information. You're welcome to reach out to me if you need to reach Scott. I can direct your information to him. I work for you, so it is not an imposition to hear from you because you are our clients. So thank you very much.
Thank you very much, Dr. Grubb. Those were wonderful resources to have. And what a great summary at the beginning of this conference. And also what a great day. I was driving in here, looking at the beautiful fall leaves and a perfect weather. I think we chose the date perfectly and we chose the venue perfectly as well. And it looks like the easiest place to get to, and it's good to see all of you here. So the day one, our focus is on research to practice. And we couldn't think of a better person today to speak on that than Dr. Shah, who is going to be speaking on how to scale up services for early course psychosis individuals using data. So he has really been taking this as a big theme of his work. I have known Jay for the last several years, ever since he began his psychiatry training at Beth Israel, and he was a star resident, and that was obvious from the very get-go. So he then went on to do a early psychosis fellowship with our friend and colleague Vinod Shah at Yale, and then went on to Montreal, where he is the co-director of the PEP program, and also the director of the Early Intervention in Psychosis program at the Douglas Hospital. And Jay has, he straddles this important interface between understanding the neurobiology of psychosis as well as developing services and implementation science in this illness. He has been developing in parallel. He's not going to say much about that today, but he's been developing a way to think about early course psychosis in a transdiagnostic staging framework and embed that into a stepped care model of services. So some of these ideas come from how we understand the neurobiology of early course psychosis, as well as from a clinical phenomenological standpoint. He has then taken that on, being a clinician himself. He has applied those ideas to developing services in a meaningful way based on real world data. So without much ado, let me bring Dr. Jay Shah.
Thank you, Kesh, and thanks for the invitation. It's actually lovely to be here. As you said, I was a resident here 2008 to 2012, so it's nice to see old friends. I see a couple here, and hopefully to meet some new folks as well. It's very meaningful to be back and on such a beautiful day as well. So, as Kesh said, right, I did my residency here, so I'm coming to you today kind of less as a researcher and a little bit more as a clinician who I see patients a couple days a week. I'm deeply involved in the day-to-day management and workings of our early intervention service. And so I wanted to make sure that, well, first of all, I wanted to make sure I have the right PowerPoint up. Will it take me there automatically? Ah, perfect, thank you. Okay. So that's the perspective I'm bringing today to this. I don't have any conflicts of interest to declare here. And as I said, my perspective is very much today that of a clinician and someone who's really embedded in clinical work and not just research. The hope is to sort of use research to improve clinical services, first and foremost, and to use data and evaluation to improve clinical services. So, right, early intervention, my first experience in early intervention clinically was here in Boston, in Jamaica Plain, at the PrEP clinic many years ago. And it really motivated me to get involved. And part of the reason was a recognition of how far we've come, right? So this is what sort of a group of paretics way back when, demonstrating just how uniform and how sort of uninformed we were at that time about the potential for recovery. And there have been various waves of mental health service reform in the US, but also globally. You see here Pinel cutting the chains of patients in France. And then back to the American context here, there was deinstitutionalization. And certainly that was controversial and remains controversial, but it was a wave of reform. Now what we see is sometimes we see these depictions of sort of brains as gears. What I really like to think about it is with early intervention being the next wave of reform and moving from kind of a splatter to a flourishing for the young people we are here, or we do our work to serve. And in many ways, the journal Early Intervention in Psychiatry sort of got this right on its cover, because what you see is this idea of a new dawn, right? This sort of next wave or next generation of services, which were really built to appreciate or recognize or foster a new way of doing things. So I thought I would maybe start by reviewing stuff that many of you know, which is kind of what is the point of early intervention? What are we here for? What were we here for? Where did the ideas come from? And how we can sort of do things moving forward. And then I'll talk a little bit about, as was alluded to earlier, the need for data in order to make the changes we want to see happen. And this will be less about methodology or statistical approaches, much more about some projects that we and my colleagues have undertaken that really use data to drive service innovation. Okay, so early intervention and this idea of the critical period or window. And the focus here is really that at the onset of psychosis or around the onset of psychosis, things can go in a few different directions. On the one hand, there's a group of folks who have a single episode and they seem to do better. They don't have a subsequent episode, they do well, they return to the sort of lives they were leading, and that's kind of Bob's your uncle, I think that may be a Canadian expression more than an American one, but there you are. A different trajectory would be that in the red, which is maybe a little bit difficult to see on the screen here, but it's one in which there's a more deteriorating course. And the idea of early intervention was to look at that and potentially the yellow line there, in which there's more of a fluctuating multi-episodic course, and to think about getting involved early and, importantly, differently, so that we might be able to foster the green trajectory or as close to it as possible, right? So the focus here is on changing the curve, or at least helping the curve be one that's closer to the green than the red. And it necessitated a focus on the first few years around the onset of psychosis. And this is from a paper with Kesh, but it's built on important work by Max Birchwood. So I want to be to mention that key piece. For a long time, and in some circles, there's been this sense that early intervention you just do stuff early. You just do the same things early. But I think it's really important for us to recognize as clinicians again, right, with the young people, we see that they're in a particular developmental phase or a stage in life. And so it's not just about doing the same things, that we would do for folks in their midlife or in their 40s or 50s and just doing them earlier. It's also about thinking about how we may need to do things differently. And so this is a paper I would recommend to folks. It's very accessible. But the idea here is that we have to think about doing things differently and not just the same things earlier. So what that means is stuff like directing attention to the onset of illness and what's happening around the onset of illness. The fact that what may emerge at the beginning may not look like what it is a decade or so later. For those who've had a more persistent or severe form of illness, we may need to be alert to and on the lookout for what the initial stages of illness are and how they may differ. And then the services themselves may need to differ from what might be presented in chronic forms of illness that may be lower doses of antipsychotic medications, really fostering and emphasizing the involvement of family or carers, and so on. And then thinking about how we build services, right, with outreach and early case identification to places where folks may otherwise have difficulty finding care or knowing where to access care. And in parallel with that early intervention, which I suspect is an issue close to many of your hearts, is that there's been a real emphasis on inclusivity, right? And particularly that for the vulnerable and underserved populations that many of us take pride in working with. And in Canada, certainly, and based on my experience here, none of this can happen alone. Clinicians do an amazing job, but it has to happen in partnership with other services, other sectors, and other stakeholders. And so, we have this kind of, this is a cartoon sort of figure, but what we could have, right, what we want ideally is for, at the onset of psychosis, for it to be recognized and supported, instead of there being questions about what's happening and why and where to go, and people being frustrated or concerned. When people seek help, we want that help to be supported and guided in a friendly and kind of youth-aware approach, rather than people needing to figure out and be detectives to find how to seek the appropriate care. And when care is found, we want the referral process itself to be really smooth and kind and supportive, rather than sort of hard landings, as you might say. And then in terms of the treatment itself, right? So we want to make sure families are aware and involved to the extent possible of the needs of the young person and the developmental things that are happening at that time. The environment itself of care needs to be multidisciplinary. This is not psychiatrists alone, right? There needs to be an openness to non-traditional approaches and thinking about how we need to meet people in the community and be as flexible as possible. We know that there are comorbidities around that same time, as there are later as well. And that in many cases, the young people we're seeing are also trying to figure out what their life holds for them, what's changed, and what they might want. And that may not be the same after the initial episode as it was before that. And we need to think about that along the way too. And in our service, we sort of categorize these buckets in terms of early identification, and we have specific things we do for that: outreach, linkages with family doctors and pediatricians and other units. We want to make access itself really rapid through an open referral system. People can walk in, they don't need a formal referral from a physician, 72 hours before a guaranteed response, and then the care itself needs to be appropriate. But certainly in Canada and elsewhere, we are still faced with challenges, and it's for these challenges that we need data, right? So we need to think about appreciating those challenges and understanding them better in order to make improvements. In Canada, in some places we still have, or in some specific communities or subpopulations, we have long durations of untreated illness. We know that the reach of early intervention services, which in Canada has grown dramatically actually, is still missing a good chunk of people. Potentially up to half of the folks who could benefit from early intervention services are not getting it, even when there's a well-established early intervention service in that area. We know that many of the folks we treat struggle with housing insecurity, incarceration, and other adverse experiences. We haven't done as good a job as we need to with integrating peers and those with lived experience into the delivery of services and the scaling up of services. And then there are gaps in other ways in terms of how we take data and move it into action. People talk about universal health insurance in Canada, but it's not as robust as it might seem. So for example, international students who are often what we see in our service, they don't have insurance that provides the same coverage. And so those are issues that we grapple with all the time. And then the contexts themselves vary from setting to setting. So I wanted to just give a few examples, building on that background, about how we have used data to think about some of this in our service. And it's a service in which we've sort of built routine collection of data into a lot of what we do. And I'll present sort of 3 examples. And I think, most of us are clinicians here, or at least have some clinical background. 3 examples that hopefully folks can identify. The first is data to sort of understand what we might want to use as the targets for intervention. The second is an example in which we use data to understand the effectiveness, or if our interventions that we were proposing and undertaking as pilot projects are working. And the third is a more recent example led by colleagues of mine, in which there's some building and scaling up of networks of early intervention services in Quebec, which is the jurisdiction in which I work. Okay, so what's the setting that I'm talking about? This is PEP Montreal. Dr. Keshavan mentioned it. So this is an early intervention service first and foremost. Okay, this is not a research platform in and of itself. It's an early intervention service, and we collect data first and foremost to evaluate how we're doing, how the young people we're serving are doing, but also how the service itself is functioning. And that changes over time, right? So we don't happen to provide services on the side. It is first and foremost a service. We nest some research projects in, as you'll see, but we're built to be a service first and foremost. And we're located at an institution, a mental health institution, but really we've tried to focus on community reintegration. I'm happy to talk about that in the Q&A if need be. We see patients with both affective as well as non-affective psychosis for a couple of years, or up to 2 years of follow-up. This is a group that we've defined as about age 14 to 35, and it's in the southwest of Montreal. I'll show you in a second kind of the map. And we're in a part of Montreal, which is in Quebec, so it's a francophone province, but we happen to have a lot of anglophones and allophones as well. So we serve folks from from a variety of linguistic communities. We have a large proportion of immigrants and visible minorities, a pretty broad spectrum of socioeconomic status in the folks who come to us. And really, again, the data is first and foremost for evaluation purposes. So that's on the left there, you see where Montreal is in the context of North America. And on the right there, the red line is where we are located in the area we serve within the island of Montreal. And this is kind of the program and its various components, really all centered around a model of assertive and intensive case management, which we believe in many ways the psychiatrists are resources to the case managers. So we really believe that the case management is at the center of it all and is more flexible and able to sort of roll with things as they evolve and change. And we have case managers from a range of different backgrounds: social work, occupational therapy, psychoeducation, nursing, and so on, but they all serve a case management role. And we assign the case managers based on their background according to what we feel the needs of those clients might be. This Venn diagram simply to say that we do a lot of outreach. These are those components of early intervention. We do a lot of early case identification, outreach. We provide phase-appropriate, evidence-informed care, but a lot of this is underpinned by data, okay? And so, again, these three examples that I wanted to share, and we'll start here. So I think most, if not everyone here, is a clinician. Is disengagement something that you grapple with? Disengagements from services, right? Like we've all seen it. We grapple with it in Montreal too. I've never met a clinician who feels disengagement is not a problem. Okay, especially in early intervention services. So we've tried to understand better, knowing that there are a number of predictors or factors that play into disengagement. We've tried to understand better what the predictors or the variables that drive disengagement are coming from. And there's a lot known about this and written about this. But of course, you can imagine that it varies from setting to setting. So if you're working in a setting in which there is a high proportion of immigrants or visible minorities, the factors that drive disengagement may be different from a setting in which that isn't the case, or depending on the socioeconomic status or the needs of those communities. In ours, as I mentioned before, we have a high proportion of immigrants and visible minorities, and we wanted to use the data we collect routinely, including social demographics, as well as disengagement or engagement in services, to understand better what was happening. And it's known that disengagement varies depending on visible minority status and also based on immigration status. So first generation versus second generation versus non-immigrants. We defined in our work disengagement as 3 months of no contact with the case management or anyone on the team, despite a lot of assertive outreach, calling, texting, and so on to see. And overall, in a population, we're talking about 300-400 people in this sample, about a quarter of them had disengaged before the 2 years. Okay. And what we looked at, you don't need to worry too much about the figure on the right, but simply to say that we looked at disengagement rates across immigrant groups, first generation immigrants versus second generation immigrants versus non-immigrants. And we found that there was actually no difference in the rates of disengagement across these groups. But what we found when we examined each group specifically was that those who disengage, depending on the group, differ in terms of the predictors or reasons for disengagement. So there are some common factors across all of these, medication adherence being a key one, but depending on the generation of, like for second generation immigrants, material deprivation was a major driver of disengagement, whereas for first generations, the first generation immigrants, age was a predictor of disengagement. So this is an example of how we can use data to identify what we may want to think about as major predictors or risk factors for who might be vulnerable to disengagement. And it tells us, and it means that if we want to do outreach work or intervention work focused on that, that we may want to take a multi-pronged approach. For first generation immigrants who are patients, we may want to think something about a different set of issues than for second generation immigrant patients and so on. We went on in this work to think about doing some qualitative work, and I should say this was work led by Dr. Anika Maraj, who was a resident with me. Montreal, as I mentioned before, is a bilingual city, and it's a lovely city. So if anyone wants to visit, you're very welcome. The food's good, restaurants are great. But our original inhabitants were First Nations people or Indigenous peoples, as is true across much of North America. But we're a French-speaking province in an English-speaking country and continent, or primarily English-speaking country and continent. So there is, in the Quebec sort of socio-political context, there's a fear of sort of losing the language. And within Quebec, Montreal is a bilingual city. So you're a bilingual city in a Francophone province in a primarily English-speaking continent. So those tensions are sort of throughout. And knowing a little bit about that, what we wanted to do was to extend the previous analysis to think about based on preferred language. Okay, so what it seems based on this analysis is that even though PEP matched patients with providers in terms of language preference, so those who preferred English would get a primarily English-speaking provider and vice versa, it looks like the preferred English speakers are more likely to disengage over a couple of years than those who prefer to speak French. So there's some really interesting stuff happening here. We looked at the data a number of different ways, and it's very hard to it's very hard to not draw this conclusion. And I can talk if there are questions about in the Q&A about this. Our thoughts are that, this, for clinicians, this may matter for a few reasons, right? One is, this is some of the qualitative work we did. I noticed, this is from a patient, I noticed that when talking to my psychiatrist, syntax was important, right? So this is sort of a more technical aspect of language. Depending on if you're French or English, sometimes it's upside down. And depending on if you think in French and if you're talking in English, you might make that syntactic mistake. Okay, so that's one comment. So kind of focus on how people speak. Another patient, to expand on language, a thing that I noticed, and this isn't necessarily a matter of like French and English, but using the language that the patient or client uses to describe themselves and describe their experiences is super important for me. This was a thing that was a barrier, right? So just the familiarity and comfort level with being able to express oneself in one's preferred language is really important. And then this is something really interesting, and I always chuckle about this quote. So the moderator in these focus groups asks around and asks to a particular participant, do you think that your clinician speaks the same language as you? The participant says, well, what do you mean, technically or metaphorically, right? So someone can speak, but they may not be sort of speaking the same language in a broader sense. And part of the observation, if we let the quote run out a little bit more, the observation that the participant was drawing on was that the health system as a whole is increasingly structured as kind of primarily Francophone with Anglophone being secondary. And so that was what they were commenting on about the metaphorical aspect or of the priorities and how the priorities are posed in a broader political setting. So all of these layers really impact on the experience that our patients have and may in fact be impacting on things like disengagement, which we've kind of measured as a sterile concept, but you can see how it ties into so many other things that our patients experience. Okay, so that's an example, right? How data ties into all sorts of other things and may give us clues as to what's important. Okay, so hopefully I've convinced some of you that data is important based on that example. Example 2, homelessness, right? How many of us have worked with folks with housing insecurity or homelessness or precarity? Yeah, right, all of us. So hopefully this example for those who remain unconvinced will be more convincing or equally convincing. So this is really about the use of data to see if the interventions we're trying to put in place are working. And we need data. We need it to kind of demonstrate to our funders, to philanthropists, whether what we're doing matters. So we know housing is really important for recovery, right? Social, vocational recovery, and precarity in housing for young people with psychosis is often present. The challenge that we experience in our local setting is that the community housing resources that were available were not well suited to our clientele. They were often organized around folks who'd had more persistent illness and were quite a bit older than the clientele who came to us. And so, because there was an effort to combine folks in older age groups with those of our younger population. And so we had a concern about that. There's also a sense that housing supports require people to prove that they have disability payments. And part of the spirit of early intervention services is actually about reintegration into vocational trajectories, right? So there's a tension here that we were trying to grapple with. And then there are other pieces like, young people want to see their friends a lot of the time, but if you have no visitors allowed, that becomes actually quite difficult. So practicalities mattered and presented barriers for our clients to feel comfortable in housing options that were available to them. And so what we did was to put together a project that was really about housing first principles and early intervention, thinking about the intersection of those. So for this, we really needed to collect data, and you'll see how. And we needed to actually find funding and resources from other sectors, including our hospital foundation, the health system and service as a whole, to put money into a clinician who could help guide this process for patients. So the key sort of partnership was key here. So what we did and what we proposed was a program that would offer our clients who are awaiting or held up from discharge in hospital or precariously housed a housing option. And this was not contingent on being in remission. People didn't have to prove that they were vocationally engaged. They didn't have to prove that they weren't using substances. They didn't have to prove that they were adherent to medications. It was in the community. There was an OT assessment provided that would actually there was an assessment, they would take people to see apartments on their own. And the case manager who was hired for this through the health authority actually worked with landlords in a manner that happens with vocational services or IPS to really guide the landlords around some of the needs that clients might have. So the focus here was on living skills, building those along with working with client goals, and a lot of focus on helping people budget, and they would contribute a little bit of whatever income they had to it, and then meet in the community setting as well. So the idea here, as I mentioned first, was to really combine principles of early intervention with housing first principles. Housing's a human right. People shouldn't have to jump through a ton of hoops in order to be able to be securely housed. And housing and treatment shouldn't be contingent on each other, recovery orientation in general, and so on. So the housing option we had, the program we created, was one that lasted for a couple of years, even if it was beyond the 2 years of services that we've provided. And they would continue to receive early intervention services throughout, contributing a small proportion of the rent, which would increase over time. And we would provide a one-year grant or a one-time grant for some basic household and furniture items to get things started. And what we thought would sort of promote autonomy and a sense of investment and belonging in that new place. Okay, so this is simple data that I'm going to tell you about, but it was actually really quite effective in convincing the partners that we engaged with to support the project. So we did some pilot work on this, 31 individuals over 4 years. You can see the age, and they were, about a year and a half into treatment. Most of them actually opted to live alone, some with others later, especially family members or roommates. And a number of them maintained, and many of them actually resumed employment and education, right? So this is fostering some of the goals that we all have. And in general, both the participants, the patients themselves, as well as the landlords, actually, which were a key stakeholder in all this, really seemed to find this a very satisfactory experience. The landlords in particular were concerned at the beginning that, how is this going to go? We haven't worked with a lot of young people with mental illness before, but knowing that there was a team that provided some support in the background really was reassuring for them. And afterward, they found that to be a very helpful part of the whole process. And they were open to working with those with mental health difficulties in the future. Okay. So again, requiring partnership across sectors. We want to continue building on this, integrate peer support better into the project, but the simple data that we collected in the last slide really showed that it was feasible, effective, and acceptable to a range of stakeholders. Again, data doesn't need to be fancy. Data is sort of across everything that we do. And then the last example, if the first two haven't convinced you, hopefully the last one will. And this is really about not just one service, but about as networks of service, like the ones who are here today, sitting together, networks of services can build and grow together and ideally learn from each other, right? That's the point of this meeting today, and I'm so glad to see it's the 5th annual meeting. So this is presumably growing, not shrinking, which is awesome. Okay, so I've talked a little bit about individual level data, individual patients. I've talked a bit about program level data, like in the last example. And we know that there are variations across programs in the clientele that they serve, in where they're located, and so on. As newer early intervention services in Quebec were emerging, what was expressed was a desire for mentorship from more experienced programs for newer ones. And the newer programs were often in non-urban settings, so in rural or semi-urban settings. And at the same time, the Provincial Ministry of Health put out this document a number of years ago, which really expressed a desire to scale this up, given that it had been established as best practice. And so moving from individual programs to regional and potentially provincial scale as well. And the context for this is this notion of a learning health system. Is that something that I've seen this articulated in the US context? The idea of a learning health system is one in which data is used to turn things into knowledge. knowledge drives changes or implementation of practice and policy, and studying that then creates or generates more data. And so it's this idea of a virtuous cycle, right? Of research, evaluation, data collection, clinical care, service delivery. So in our knowledge to action cycle, which is what the previous slide was showing, what we did was we sort of said there's a desire to capture data, to measure things at the program level and sort of at a higher level as well, to turn that data into a set of indicators and eventually standards that would be used to measure fidelity against, but to use health technologies, right? So electronic data capture and feedback, which is also a technology, right? The use of data and electronic data capture to provide feedback to services and service leaders, and then to take all of that and build capacity, both in the older, more experienced programs, as well as particularly in the newer ones. And to do that, I think it's absolutely critical to note what's on the top left of the slide here, which is that this is not a researcher-driven thing. Certainly, grants were often led by researchers or written by researchers, but you can see managers and administrators are at the heart of this, policy and decision makers, clinicians, and most importantly, service users and family members of carers. Okay, and you can see those folks are embedded in many, many of the aspects of this slide. So a number of years ago when this was started, it actually began with 11 sites, mostly in urban settings, which you can see on the right here. And I'll talk in a moment. These were selected. These are sort of a limited set of sites that were selected just to get things up and running, but there's been growth. So what you see here, as of 2023, there are 20 sites. And the plan longer term is to develop about 33 in total. On the top right is my friend and colleague, Dr. Amal Abdelbaki, a wonderful clinician who works on the other side of Montreal and is really leading this broader SARPEP learning health system project. And you can see some stats here, right, on the number of professionals, psychiatrists, patients, number of new cases a year. This is a partnership between ACUPEP, which is a network of early intervention services with the ministry, researchers, and patient partners too. And a range of indicators, right? I used the word before. So indicators that tell researchers, clinicians, program leaders, patients, family members, and the ministry about access to care and how that's going at the service level, what treatment delays are like, how engaged and satisfied service users are with the service, how engaged family members and carers are, the extent to which evidence-based practices are used, education and capacity building, patient to clinician or clinician to patient ratios, right, which is something we're often concerned about, and then self-reported outcomes too by patients about their health, their sense of recovery, their quality of life, and so on. So the idea here, right, is to use data efficiently to improve how we practice. And there, as I said, there was mentorship between programs. The patients and family members were often involved in the co-creation of some of the, or the prioritization of some of these indicators. There's asynchronous and synchronous training programming, and we just had a knowledge exchange event about a couple of weeks ago now in downtown Montreal, where we talked about sort of which of these indicators, you know, should be prioritized, which need to be taken off the table, and whether there are new ones to be brought in. And that was across all stakeholder groups. I mentioned the word technology. So you've all been to airport bathrooms, or many people have been to airport bathrooms. You're asked to say, do you like this or not? There was a version of that in the lobbies, right, of these early intervention services. So you want to make technology itself accessible, and that moves fast, hey? If you have the receptionist pointing people to that, people will tap that, just as an FYI. So, and then for a subset of folks, there was a more detailed assessment. There was feedback then provided to clinical team leaders 2-3 times a year, and then family and relatives and so on were also able to provide feedback. And you can see this is really thinking about what different stakeholders thought in terms of the acceptability of the indicators, right? So we've really tried to bring different perspectives to bear on the selection of those. And then feedback is provided to the programming to the individual programs automatically and systematically with a coordinator who sees data across all the programs. And this is not, to point fingers to say, oh, you guys are doing well in this, but not doing well in that. It's anonymous. And it's really about focused on recommendations about fidelity or sort of being more consistent with fidelity, but also areas where there may be gaps, and bringing strategies that other programs use to kind of address issues or challenges they had, and bringing those to the program for which it's in question. So it's really about knowledge sharing and lifting sort of all boats, okay? This is an example of the sort of feedback, right? So this is about access delays on the left here to a psychiatric evaluation. You can see there's old clinics, new clinics, the max, the mean, your service, and the minimum compared with the standard, okay? And then on the right here is about continuity of care after early intervention services. So just to summarize, this is really developed across stakeholder groups. It hasn't been imposed top down. It was really developed bottom up. That's the point of including all of those stakeholders. And there's been, I use the term a virtuous feedback cycle. So there's been a bit of success in a subsequent project focusing on peer support and family peer support that kind of developed as a spin-off of this initial project. So it's a more focused new project, but it allows us to really push an aspect that was missing a gap. And it allows us to go to the funders and payers to say, hey, this is an area for which there's a real need for additional emphasis and support. Basic data, again, right? Really, really critical. And we had to engage across sectors. Of note, this, I wouldn't say it's caught fire, but it's been compelling enough, not just in Quebec, but across Canada, that last year, led by my colleague, Dr. Manuela Ferrari, there was a across Canada conference on developing a rapid learning health system. This was in Montreal late last year, almost a year ago, on what a rapid learning health system for early intervention services in psychosis would be, with folks from almost every province and territory, and based on really validating the outcomes from a Delphi study that I was also involved in. Okay. And, that's the pan-Canadian LHS, but I'd like to also just emphasize that the peer support implementation project is now funded, again, led by Dr. Abdel Baki, as a project that was a spin-off of the original SARPEP project. So it was identified by multiple stakeholders that there was a gap in support and emphasis on peer support and family peer support. And the provincial government was compelled enough by the data to say, actually, there probably needs to be another funding stream for this. And that is what has emerged now. And so you can see really how the idea of a learning health system, it may identify gaps, but it also allows the highlighting of those gaps as a potential need for emphasis and renewed support and collective action around some of those needs. And again, led in part by the patients and families that we serve. Okay, so that's kind of bringing us to the end here. I, as a clinician, have talked about sort of data in a few different examples and capacities, but I hope I have convinced you that early intervention services, they're already a major reform. We want to continue doing things differently, right? And I hope the examples have illustrated that. There is still so much for us to do, in particular, integrating those with lived experience, engaging stakeholders from across different walks of life, and building partnerships in communities and with community stakeholders. And at the heart of all of this is really data, right? And in order to evaluate and make better at what we do and for who we serve. And thank all my colleagues and the clinicians with who I've worked for many years and have learned so much, and some of the trainees who've spearheaded some of this work as well. Hitch, I don't know if there's time for a few questions.